attitudinal orientation. And you note that the subtitle of this first presentation to you is the basis of proper description. It is a fact now that in the techniques you have at your disposal for clinical investigation, you can arguably see the anatomy even better than we can, because you see the anatomy as it really is, and with magnetic resonance imaging, with computerized tomography, now increasingly with three-dimensional echocardiography, you see the heart as it lies in the body. And of course, the secret of proper anatomic description, as you see in my first subtext, is that structures are described relative to the body, or at least they should be. Now we know, and you all know, that all structures have three orthogonal planes, and if you are properly to describe any structure, you need to take note of all of those planes. So if we consider this room, there's the height of the room, there's the depth of the room, and there's the width of the room. And we could not describe this room properly unless we took cognizance of all three of those planes. Now, it will not have escaped you during your investigation of patients with congenitally malformed hearts that the heart itself has orthogonal planes. And if we followed anatomic convention, we would describe those planes within the heart relative to the bodily coordinates. But we don't. So what are the bodily coordinates? If you all cast your minds back to the days you spent in the dissecting room, some of you may not have been in the dissecting room, but I'm sure most of you were, you will remember that we consider the body, the person, standing upright and facing you. This is the so-called anatomical position. And there are then three orthogonal planes when the subject is standing facing you in the upright position. The first plane runs from side to side, and we call that the coronal plane. And that is one of the long axis planes of the body. The second plane, also in the long axis, runs from front to back, and you will remember, I trust, that we call that the sagittal plane. And of course there are any number of coronal and sagittal planes going from side to side and from front to back through the body. And then the third orthogonal plane is then the short axis plane or the transverse plane, and again there are any number of short axis planes as we go from top to bottom of the body. Sadly, for conventions which I do not quite understand, when we consider the heart, we take it out of the body and we sit it on its apex. And we also twist it through about 90 degrees. And Andrew very shortly will be showing you this cast that we have of the normal heart. And for, as I say, for reasons that escape me, for 300 years, anatomists have described the heart in this fashion, which we call the Valentine heart. But now, with the new techniques you all have at your disposal, you know that this is incorrect. Because when you see the heart in the body, it doesn't look like the Valentine heart, it looks like that. You have to tilt the apex of the heart up by about 45 degrees. You then have to rotate the heart in counterclockwise fashion, so that in fact the so-called right side of the heart ceases to be right-sided and becomes anterior. And that is the way we now need to be describing the heart if you are going to be able to describe the images that you see so that everybody else looking at them can understand what you are talking about, because we should not make things difficult. So let's think a little bit about the left anterior oblique projection. This is the projection in which the adult cardiologists all the time describe the coronary arteries, and I'm sure most of you are also familiar with this plane. So here in the middle of our mannequin here, you see that left anterior oblique projection as you would see it from the front of the patient, looking obliquely back towards the right side. But the coordinates still have to be right and left relative to the arms of the patient, superior and inferior relative to the head and the feet of patients, and then most importantly, posterior and anterior, not relative to the heart, but relative to the spine, which is at the back, the sternum, which is at the front. So here is such a short axis oblique section of the heart as you would see it in left anterior oblique projection. I'm sure you will all recognize a cut like this. You've seen it in all your echocardiographic studies. And you will know that this is the diaphragmatic surface of the heart. And if now I put in my coordinates, remembering that this is a somewhat oblique cut across the heart, there is no question that the diaphragm is closest to the feet and therefore is inferior. And the top part of the heart, that which is closest to the head, is that which gives rise to the pulmonary trunk. But then we have huge problems with the current way we describe the heart, because the posterior part of the diaphragmatic mass is not that which lies on the diaphragm, but it is that which is closest to the spine. And the anterior part of the ventricular mass is obviously the parietal wall of the right ventricle, because that is the part that is closest to the sternum. And you will all recognize there is an artery there running midway along the diaphragmatic surface of the heart, and I know that all of you still call that the posterior descending coronary artery. But is it posterior? And here I appeal to your logic. Is there anybody in the room who can hold up a hand and convince me that that structure is posterior? And of course there isn't, because in reality it is not the posterior descending artery. And in fact, if you trace the artery towards the apex of the heart, in many instances it ascends as it runs towards the apex. It is in fact the inferior interventricular artery. And what sort of myocardial infarction do you get if you get blockage of the inferior interventricular artery? And you all know that the answer to that is that you get inferior myocardial infarction, because the electrocardiogram doesn't tell lies, like the anatomists do, like the pathologists do, and now like all the adult cardiologists do. A good friend of mine, John Partridge, outstanding radiologist, may be known to some of you, who has just moved to Australia, recently wrote an article which we submitted to the Journal of the American College of Cardiology, pointing out this deficiency, and the response from the editor was, well, all the cardiologists know what we're talking about when we talk about the posterior descending artery. That may well be correct, but it doesn't make it right. And in time, people will come to realize that we have to describe as they lie within the body. So let me show you another huge deficiency at the moment. You will all recognize that I've now closed in on a short axis section of the left ventricle. And let me put in for you the position of the papillary muscles supporting the mitral valve. How do we currently describe those papillary muscles? Well, you all be aware that we call that papillary muscle posterior and medial. And as you can immediately see, in fact, it is anterior and inferior. And we call the other papillary muscle anterolateral, whereas in reality it is posterior and superior. And you are all intelligent people. You would not have come to this course were you not intelligent people. So I appeal to your intelligence. Let us take on board terminology which shows and describes cardiac structure as it lies in the body, because that is now how you image it. We must respect the anatomical position. The fact that people such as myself have ignored that throughout our careers, for me for the past 35 years, that does not make it correct. I was wrong, and I am happy to admit that I am wrong. I know that it is foreign to current conventions to argue that we should use attitudinally appropriate orientation, but it's going to make it so much easier for the people who follow. In the fullness of time, I am convinced that people will realize that we must use attitudinal orientation, and this splendid aphorism, attributed amongst others to Rudolf Virchow, those who fail to learn from the mistakes of yesterday are condemned to repeat them, is 100% true.